Okay, I think we can begin.
All right. Good afternoon to my vets community. Sanbonani, Molweni, Dumelang, Dimasiare Abode, to all of you joining us from different parts of the country today. I would like to welcome you to today's Dean of Students Leadership Conversations with our very own Professor Madhi, who is the lead researcher in the development of the COVID-19 vaccine. As we may all be aware, to date, South Africa has just more than 627,000 positive cases that have been identified. And as a result, we have seen that this pandemic has not only put the national leadership of this country to test, but that also of the health system of our country. Hence, today we will be having a conversation on leading authentically in the fight of this global pandemic and the lessons learned behind it. And right now, I am just going to introduce some of the housekeeping tips. As you can see at the bottom, you do have your Q&A and chat icons. If you have any questions that you would like to ask, please just put them on the Q&A section so that we may be able to engage with you. And now I would just like to hand over to our Dean of Students, Mr. Jerome September.
Good afternoon, VITSIs. Welcome to this webinar, an exciting series where we are talking about leadership, leading authentically, and essentially challenging you as our student leaders to think about your own leadership journeys, to think about your own contributions and the path that you want to follow. We are so excited today to have someone with us who is really at the cutting edge of our current reality. The current reality, as Basit Sana indicated, of COVID-19. We're in lockdown. We've had loved ones positive. You may have lost loved ones during this pandemic. And today we're having a conversation about the finding of a vaccine, but importantly, someone at the forefront of this who is also a leader. As you will know, he is our new Dean of the Health Sciences faculty. He's been leading in different spaces at various times in his life. He's a professor of vaccinology at the University of the WITWATERSRAND, co-founder and co-director of the African Leadership Initiative for Vaccinality Expertise. He's completed his undergrad and postgraduate training at WITS, currently hold positions of Director of the South African Medical Research Council's Vaccines and Infectious Diseases Analytical Research Unit, and as Research Chair in Vaccine Presentable Diseases of the Department of Science and Technology and the NRF, and is currently Chair of the National Advisory Group on Immunization in South Africa, and is a member of the World Health Organization Strategy Advisory Group of Experts on Immunization since 2019. Widely published, someone who is walking his journey, and we are so grateful, Prof, that you have made the time to be with us today and to share some of your insights, some of your lessons. We look forward to learning from you. So I hand over to you, Prof.
So thank you, Jerome, and good evening, afternoon to everyone. It's been an unusually cold day for the start of spring in South Africa. Can someone assist me to allow me to share my screen? Someone needs to, Tembelishle, I think you need to allow me to share my screen.
I've asked that the team in the background please assist, Prof.
Okay, perfect, thanks. So you're able to see my screen, right?
Yes, Prof.
Okay, let me sort myself out. Okay, so thanks everyone for this invite to speak to the student community, and I'm not going to go into too much detail with regard to COVID-19. I think all of us are pretty much overwhelmed in terms of the data that's been coming out on a regular basis as to where the country stands with COVID-19 as well as what the situation is globally. But I think the first thing and most important thing to start off with, being on the African continent, including being in South Africa, is the recognition that what we actually understand in terms of COVID-19, both in South Africa and the rest of Africa, is very much distorted. And it's very much distorted because of our healthcare systems and largely an inability and lack of capacity to be able to test at the rate that we should be testing to adequately quantify what is actually happening on the continent, including in South Africa. So globally, where we stand right now, as most of you should know, is that there's over 25 million cases that have been diagnosed of COVID-19, of which less than 5% of that has been diagnosed on the African continent. And when you look at the African continent, where there's been about 1.3 million cases that have been diagnosed, more than half of those cases have been diagnosed in a single country, and that is South Africa. And that is not because South Africa is that unique on the African continent, but largely because despite all the challenges that we face in the country, including all of the negativity around our healthcare services, the reality is that the number of laboratories that are testing for COVID-19 just in South Africa probably exceeds the number of laboratories that are able to test for COVID-19 in most of the other sub-Saharan African countries. So although there's 43 countries in sub-Saharan Africa that can test for COVID-19, in many of those countries, you've got a single laboratory that's testing. So what that really results in is that at this point in time, we're simply not in any position to have any sort of estimates as to the burden of COVID-19 in sub-Saharan Africa. It certainly is not making up less than 5% of all of the COVID-19 infections that have occurred up to now. That would be a complete underestimate. And even in South Africa, where we've got the highest rate of testing on the continent, except for Mauritius, our testing rate still lags behind many high-income countries. So my estimate, as an example, right now in South Africa is rather than having 650,000 people that have been infected, that true number is probably at least 7 to 10 times higher. And that just sort of illustrates where we are in terms of largely a lack of adequate understanding in terms of the impact that COVID-19 has had on the health front in relation to people being infected and possibly also in relation to people dying. So what we know in South Africa as an example is when you look at the Medical Research Council and their estimates in terms of excess mortality from natural causes of death over the past 5-6 months, the excess mortality compared to what is expected for this time of the year is about 5 times higher than the number of COVID-19 deaths that have been reported. And what that tells us is that there's a systematic under-reporting of COVID-19 deaths. And again, there's a variety of reasons for that. It's not something that is being done purposely on the part of government. Is simply our healthcare systems and our inability to test at scale. Now, for many in the student community, the big question you're asking is that, well, that's fine, but we seem to be on the wane in terms of this particular outbreak. And things seem to be getting better. The number of new cases that are being diagnosed is decreasing compared to at a peak, where there were roughly about 14,000 new cases that were being diagnosed on a daily basis. That has now gone to about 2,500. So that is good news. It means that this particular wave of the outbreak is subsiding, but it certainly hasn't come to an end. And I think what we need to appreciate for this virus, which is very similar to experiences from past pandemics, including the influenza pandemic from the 1918 and subsequent influenza pandemics, is that this virus is not going to go away, unfortunately, at the end of 2020. In all likelihood, what we're going to experience is a further outbreak and perhaps another 2 or 3 outbreaks before this virus becomes more of what I would term as a nuisance virus. It still circulates in the human population. It still causes people to become sick. It still causes people, unfortunately, to die. But the rate at which that occurs is much less than during this pandemic period. So where do we stand? We're on the wane in terms of this outbreak, and it's almost impossible to predict as to when the next outbreak is going to occur, as well as what the magnitude of the next outbreak is going to be. So it's dependent on a number of different factors, and key amongst those factors are two issues, or three issues. The first issue is what percentage of the population, what proportion of the population has been infected this time round, because by being infected, what ends up happening is that you recover, and the reason people recover is not because of any miracle or our healthcare system. So when we talk about 83% or 90% recovery, that is what we expect. With this particular virus, in fact, we expect 98% recovery eventually. And the reason for that recovery is because of our body's ability to mount an immune response, which is able to get rid of the virus and prevent its progression in the majority of people that are infected. So between about 95% of people that are infected with this virus would either be completely asymptomatic, or they will have a mild illness and they'll recover without needing to access a hospital. And the reason for that recovery is because of the body's immune system to actually mount a response against the virus, bringing its replication to an end in the body and preventing its progression. Now that immune system, which is able to do that, also is able to develop what we call a memory response. And that memory response is extremely important in terms of future exposure to the virus, and how well and how quickly you'll be able to terminate the progression of that viral infection from resulting in severe disease. So the proportion of individuals that have been infected this time around in South Africa, coupled with the durability of this immunity, which we're not yet too sure about when it comes to SARS coronavirus 2, together with the behavior of citizens in terms of adherence to the non-pharmaceutical interventions, the avoiding of mass gatherings, the wearing of face masks, the physical distancing, those sort of combination of factors will largely influence when the second outbreak is likely to occur, or when we probably might start seeing another peak with this particular wave of the outbreak. Like I said, it's extremely difficult. If you ask me to make an educated guess in terms of what I think would happen, my prediction is that we probably will see an increase in terms of number of cases come around about early February of next year. And the reason for that, unfortunately, is because similar to what is being experienced in the United States and in Europe, is that when people have gone off on vacation during the summer period, there's a lot of mass gatherings, there's poor compliance and adherence to those non-pharmaceutical interventions. It allows the virus to still start transmitting to the susceptible population. And when people start coming together again, you get this transmission taking place at a much quicker rate, and you start getting this rebound. In addition to which there might be some climatic factors that contributes to this. So the short is that we are unfortunately still in for a long haul. COVID-19, this pandemic is not going to go away at the end of 2020. It's going to be with us, but hopefully the next wave will be less severe than what we experienced this time around. And to some reason, for some extent, the reason for that is based on our experiences in our vaccine trials, where when the volunteers came forward and they needed to be screened to see if they were actually infected with the virus before they could enter into the study, we found that in some populations, some communities, 20 to 25% of people that were completely asymptomatic that were volunteering were found to be infected with the virus at that point in time. So there's been a huge amount of infection that's occurred in South Africa, which we simply haven't picked up, simply largely because of our limitations in terms of being able to test at scale. So like I said, the virus is not going to go away. And even if this pandemic ends, this virus is going to be ongoing. So we're still probably going to require a vaccine. Now, where are we with vaccines? Currently, and this is an outdated slide from 2 weeks ago, and these numbers would have changed completely in the past 2 weeks. But we're facing a situation right now where it's been unprecedented in terms of the speed that's occurred with the development of COVID-19 vaccines. So there's more than 150 vaccines that are in different stages of development. Most of those in the laboratory still or in preclinical development. But in humans, there's close on to 29, about 40 vaccines already now that are already in human trials. And there are different phases of these human trials. And I'm not going to bore you in terms of the detail of the different phases, but usually the vaccines need to be evaluated in different stages with increasing sample size to eventually determine whether the vaccine is safe as well as effective in protecting against COVID-19. So phase 3 is sort of your end stage where it's just sort of pre-licensure studies, large studies involving up to 30,000 individuals in each study. And that helps us to understand whether the vaccine is safe, what is the safety profile, what are the uncommon side effects of the vaccine, as well as whether the vaccine protects against COVID-19. So usually the timeline for developing a vaccine ranges anything from 5 years to 20 years, usually a timeline of about 10 to 15 years. Now with COVID-19 vaccine, what we're trying to do is condense this 10 to 15 year timeline into a period of 10 to 15 months. So a substantial reduction. Now that comes with certain risks. And the biggest risk that we face is that although there's probably 40 vaccines that are currently in clinical trials, we will be considered to be highly successful if even 10%, even 4 of those 40 vaccines are eventually licensed in the next 12 to 18 months. The legacy of vaccines is that only 10% of vaccines that go into clinical trials are eventually licensed because many of them end up not showing efficacy, not showing that they're able to protect against a disease of interest. So there's a huge attrition rate in terms of the number of vaccines that go into clinical trials in relation to how many eventually get licensed. Now, what's happening with COVID-19, unlike the traditional approach where each of these phases take different sort of, take place in series, with COVID-19, we find many of these phases of the study, of the vaccine evaluation is taking place in parallel. So we've got phase 2 studies that are running in tandem with phase 1 studies, and those phase 2 studies then are being adapted in terms of their methodology based on the findings from the phase 1 study, and similarly so between a phase 3 and phase 2 study. Even for a phase 1 study, usually you would embark on these studies after you've done sort of preclinical work in animal models, including in non-human primates as an example, to see whether the vaccine works as a proof of concept. What's happening here is that we find that the phase 1 studies are occurring in parallel with the preclinical studies or the non-human primate studies, and all of this really to try to get a vaccine before this pandemic blows over. And this pandemic will eventually blow over without a vaccine, purely by virtue of natural immunity arising when a large percentage of the population become infected. But that comes at a cost. And the cost that comes with is excess mortality that could otherwise be prevented compared to if we had a vaccine that was developed sooner rather than later. Now, there's a number of different technologies, and I'm not going to bore you with this here, but there's a number of different technologies that are being used to develop COVID-19 vaccines. And some of these are using a more traditional based approach, especially the protein-based vaccines. But for other technologies, such as the nucleic acid-based vaccines, these are technologies which simply have not been used previously to actually develop a vaccine. Even for the viral vector-based vaccines, there's only the Ebola vaccine that's been developed using this particular technology. So these are novel technologies that are being used to develop a vaccine against a novel virus, and that obviously comes with some risk as well in terms of a greater likelihood of being unsuccessful in terms of showing efficacy with that sort of approach, because we really don't know whether the immune system is going to be able to respond to that sort of approaches in the same manner compared to natural infection or more traditional approaches in terms of vaccine development. Now, why are we involved in vaccine studies in South Africa? So right now we're conducting 2 studies of COVID-19 vaccines in South Africa. And in fact, these are the only 2 studies that are being done on the continent. And when we embarked on the studies, there was sort of almost a knee-jerk expected reaction from a small section of the population saying that we shouldn't be doing vaccine studies on the African continent and not in South Africa. And this was a gathering outside at Senate House, a group of about 20 individuals. And when the media interviewed them about the reasons for being there, they had about 20 different reasons why they were there and why vaccine studies shouldn't be done in Africa. But one of the factors that precipitated this sort of a reaction was the rather unfortunate sort of statements by two French scientists, which was actually in relation to evaluating BCG vaccination as to whether that protects against COVID-19. And they made a suggestion that because of Africa's healthcare systems, that's an ideal place to actually evaluate BCG vaccination as to whether it protects against COVID-19. Obviously, that caused a huge amount of uproar, and that sort of pushed the back of scientists, pushed the scientists back against the wall in terms of needing to defend a position which simply didn't speak to the realities of the situation and which was sort of, in a sense, provocative. Now, where do we stand when it comes to vaccine trials and generally clinical trials on the continent? So there's this misconception that Africans are used as guinea pigs when it comes to clinical trials. Now, there couldn't be anything further than the truth. And the reason for that is when you look at, this is data from 2018, and if you were to do the same search in 2020, unfortunately, this number simply wouldn't change, is that less than 5% of all clinical trials in the world are done on the African continent, less than 5%. That despite more than 18% of the global population living on this continent. Now, with such few number of studies done on the African continent, it actually comes at a cost. And I'll show you what cost it comes to the livelihoods and the lives of Africans when we don't do studies in a timeless manner on the continent and the impact that it has had in terms of survival, especially of children on the African continent. So less than 5% of all clinical trials are actually done on the African continent. And for many of the studies, unfortunately, these are clinical trials which are really not cutting edge. These are behavioral studies in terms of behavioral sciences and a whole lot of other things. Very few in terms of interventional studies. And as I mentioned, with the COVID-19 vaccine right now, there's 40 vaccines that are in human trials. Many of those vaccines are being done in multiple countries, so there's more than one study per vaccine. But out of probably roughly about 70 vaccine studies that are currently underway, there's only 2 that are being done on the African continent. And those 2 studies wouldn't be done in South Africa right now had it not been for our efforts to actually reach out to the developers of those vaccines and to convince them that we need to get these vaccines evaluated on the African continent at an early stage in terms of its clinical development, so that we can have some sort of success in terms of timeless access to these vaccines, should the vaccine shown to be effective. Now, what has been the consequence of not doing these sort of studies at an early stage? And this is a different vaccine known as a hip conjugate vaccine. So this is a bacteria. This vaccine targets a bacteria that was the leading cause of meningitis, infections around the brain in children, as well as the leading cause of infection of the lung. And what this data basically shows you is that when you compare the introduction of this vaccine, so this vaccine became available in high-income countries in the late 1980s. And within a 3-4 year period of becoming available, close on to 90% of high-income countries were already using this vaccine as part of the public immunization program. In Africa, 5 years after this vaccine was actually introduced, it had been licensed, very few countries, low-income countries had introduced this vaccine. In fact, it took 20 years from the time of the licensure of this vaccine in high-income countries to the time where more than 90% of low-middle-income countries introduced this vaccine into the public immunization program. A 20-year lag in terms of introduction of a life-saving vaccine into public immunization programs, largely because we weren't involved at an early stage in terms of the clinical development and evaluation of this vaccine on the continent. So that comes at a huge cost. So this particular bacteria, in the year 2000, as an example, caused roughly about 350,000 children to die each year. 90%, 95% of those deaths were occurring in low-middle-income countries. And that was a time when a vaccine was already available for close on to 5 years in high-income countries, yet it was causing about 350,000 children to die. With the increase in terms of uptake of the vaccine over time, what we've now seen is a decline in the terms of the number of children that are dying in low-middle-income countries from Haemophilus influenza type B to less than 50,000. But that only resulted 20 years after the availability of this vaccine. And the reason for that, like I mentioned, was because of the lag in terms of when those vaccines became available in low middle income countries. Another vaccine, two other vaccines that I was closely involved with in terms of clinical development were the pneumococcal conjugate vaccine, which prevents the leading cause of pneumonia in children, and Rotavirus, which prevents the leading cause, which was responsible for the majority of deaths that occurred from diarrheal disease in children. With the pneumococcal conjugate vaccine, a very similar story. It took almost 10 years from the time of the licensure of the vaccine in high-income countries and availability in high-income countries before it actually became available in low middle income countries. And in fact, South Africa in both instances was the first country on the continent to actually introduce both the pneumococcal conjugate vaccine as well as the rotavirus vaccine into its public immunization program. Now again, with pneumococcus, which used to cause up to 600,000 deaths each year in children under the age of 5, with the majority of these deaths occurring in low middle income countries, it took us 10 years to basically halve those sort of numbers by increasing the access of the vaccine to children in low middle income countries. Why was South Africa in a position to make an informed decision in terms of the early introduction of this vaccine into the country? And one of the major reasons for that is because, fortunately, in my research unit and the rest of the research team, we were very much at the forefront in terms of the clinical development of these vaccines. So we did the first studies, not just in South Africa, but on the continent, and in fact, from any low middle income country on these vaccines in terms of how they worked in our population and developing the case and allowing for advocacy to occur, informed by hard data as to the potential public health impact that these vaccines would have in South Africa and on the African continent. And again, because of the work related to because of the studies that were done in South Africa in terms of the clinical development of this vaccine, that led to the World Health Organization to make recommendations for the introduction of these life-saving vaccines into public immunization programs, especially in all low middle income countries. So largely informed by the work that was done at this university, it really informed the global agenda in terms of the introduction of these life-saving vaccines into public immunization programs in low middle income countries. Now, some of us might have forgotten that this is not the first pandemic that's occurred in this century. In fact, this is the second pandemic that's occurred in the century. The last pandemic was actually in 2009, swine flu. And there was some sort of interesting comparisons between this interesting sort of commonalities between swine flu and what we're experiencing with COVID-19, and especially when it comes to quantifying the burden of disease. Like I said, we've got a major underestimate in terms of the number of people that have been infected on the African continent, the number of people that have died on the African continent because of COVID-19. And this was not just similar to what happened with swine flu. During 2009, 2010, during the pandemic, the fewest number of cases of swine flu that were reported globally were from Africa and South Asia. They reported less than 5% of all of the swine flu cases that were being diagnosed globally from South Asia and Africa. Despite that, after the pandemic passed, when they did an analysis using some modeling and looking at excess mortality, they were able to show that those two regions, Africa and South Asia, in fact contributed to more than 50% of all of the deaths that occurred with swine flu, despite having reported the lowest number of cases when the virus was actually circulating. And this really speaks to the issue in terms of our healthcare systems that are simply not equipped to basically deal with these sort of outbreaks and occurrences, even under the best of circumstances. And for me, a best of circumstance in sub-Saharan Africa is what exists in South Africa. And even then, we're still coming short. We're doing a good job, but we're still coming short in terms of fully being able to quantify the impact that COVID-19 is having in terms of health, let alone other indices such as the economy and the livelihoods of people. So what happened with swine flu? Not dissimilar to what's happening with COVID-19 vaccines, there was a huge flurry of activity in terms of development of a swine flu vaccine. Unlike with COVID-19, where we've now doing studies right at the early stage in terms of the clinical development, with a swine flu vaccine, there was no study that was done on the African continent. There was no study done in any low middle income country with a swine flu vaccine. What happened is that South Africa eventually did gain the access to the swine flu vaccine, but it only gained access to the vaccine after the pandemic had passed. And after the virus had become sort of more of a nuisance virus, it did not have access to the vaccine at the time when the population was most susceptible and most vulnerable to actually dying and developing severe disease from swine flu. And that is something that we can't allow for to happen again with COVID-19. And that is the reason why it's essential that as South Africans, as Africans, that we actually form part of the global initiative in terms of being involved in the clinical development of COVID-19 vaccines. Unfortunately, the reality in the African context is that we in Africa have not invested in science. We have not invested adequately in science. And when I'm talking of the we, I'm talking of it in relation to governments, in relation to the private sector, as well as in relation to academia. And us not investing in science does not put us into a position to actually develop these vaccines from scratch. On the African continent, besides for Senegal that produces one vaccine known as yellow fever vaccine, and some of the North African countries that produce a few basic childhood vaccines, there's absolutely no capacity to manufacture vaccines, let alone discover vaccines, and take it through its entire development pathway. So we've got dependencies in relation to other countries and other private sector outside of the continent with regard to gaining access to vaccine. But the only way we're going to be able to make a case to be able to gain access to COVID vaccines in a timely manner is essentially by being involved in this clinical development and clinical evaluation at an early stage. So I'm not going to take you through this little graphic, but what it really tells us is that there's different stages in terms of the development of vaccines in general. And eventually we're wanting a phase 3 study to be successful, but that is not the end road in terms of the whole issue of COVID-19 vaccination and immunization. In fact, for Africa, that is really the starting point of the challenge, because much of this work in terms of the clinical evaluation of vaccines can be done in other countries. The big challenge that we're going to face on the continent, not dissimilar to our past history, in terms of other life-saving vaccines, is one of access, especially one of timeless access, where right now what we're seeing emerging globally is sort of vaccine nationalism, where countries, high-income countries, are literally investing billions of dollars to purchase vaccines which have not yet been developed, but they've already put their purchase orders in place. And obviously that is going to result in immense pressure in terms of our ability to be able to gain access to those vaccines at an early stage, or at a relatively early stage after it's actually being developed. In the absence of doing that, the unfortunate reality, or the unfortunate African reality at times, is that we end up defaulting to false science. We end up defaulting to trying to promote remedies which simply don't work and haven't been evaluated scientifically, and that is dangerous. And that is something that we simply can't afford to entertain this time around again. So hopefully that was a good enough reason to perhaps entice you to consider participation in one of our vaccine studies. Like I said, we are undertaking 2 vaccine studies currently, and if you are interested in any of the studies and more detail about the studies, if you go to the WITS website, you'd be able to get more information. Thank you for your attention.
All right, thank you so much, Prof. So now we're going to move into our Q&A section, and we're gonna start with a chat from one of the people that are actually that have actually joined us, and it's a question from Lara Dunwell, who says, Prof, you mentioned that we may have a second wave post our summer holiday period in February 2021. Given that many visitors to SA come from the Northern Hemisphere for their vacations, do you anticipate that we will have multiple waves once our borders reopen? Visitors' seasonal travel and South African seasonal travel might make us additionally vulnerable all year. So that is the question, that do you anticipate that if the country reopens, we will have multiple breakouts? So that's what the question is saying.
Yeah, so certainly international travel would contribute in terms of importation of new cases and new sources of transmission. But I think in South Africa, because of how widespread the community transmission has been, it's unlikely that international travelers are going to sort of add much fuel to that burning fire. And in a sense, it is a burning fire now. So it's not to say that COVID-19 is going to disappear if we keep our borders locked, and that we're not going to have a second wave if we keep our borders locked through to February of next year. We're still probably going to have a second wave. But like I said, fortunately, my estimate right now is that that second wave, irrespective of to what extent international travelers might or might not contribute to it, is very likely going to be less severe than what we've experienced this time around. And interestingly, even what we experienced this time around actually falls very short of what the modelers had predicted to be even the optimistic case scenario for South Africa with this outbreak of COVID-19. And there's other reasons why that might have transpired, which I'm not going to go into the detail on. But safe to say, I think a large percentage in some communities, I believe that 35 to 40% of people, especially in highly densely populated communities, have been infected. And once you reach that level of infection, there is what we call community immunity, or in a sense, herd immunity. And that is what's probably driving this wave downwards, where because a large percentage of people in the community have become infected and develop immunity, that interrupts the chain of transmission of the virus, and that lends itself to the sort of waning of the outbreak, despite us having moved from a highly restrictive level of high level of restriction in terms of movement to a lower level of restrictions, moving from level 5 to level 2 while the epidemic was actually surging. We've seen an eventual wane in terms of this outbreak, and it's, I think, all got to do with community immunity. So I don't think opening the borders is a major issue. In terms of what to expect to occur in South Africa, unfortunately, like I said, we're probably going to experience a second wave, but that's all got to do with our own behavior rather than the behavior of foreigners.
Okay, I think that was well answered. Thank you so much, Prof. And just to tie in to that question, considering that we are headed to our summer weather, so someone is asking that in your experience, how influential is the summer weather on the case presentation?
Yeah, so I think that's a really important question, and there might be a climatic factor associated with the SARS coronavirus too, which might also explain what is currently happening in Italy, in Spain, in the United States, and they're pretty much experiencing sort of a second outbreak. Yes, they've transitioned from initial winter outbreak, gone through summer, and now they're sort of seeing a resurgence as they enter into autumn. And for many respiratory viruses, and obviously the classical example is influenza virus, there's a very strong climatic association in terms of the circulation of the virus. And the reasons for that is twofold. One of the issues relates that many of these viruses, the climatic factors, relatively sort of not too hot weather, low humidity actually enhances the ability of the virus to survive. In addition to which, there's sort of same climatic factors, dry sort of environment, cool weather, actually increases the host susceptibility to actually being infected by viruses. So it's both the host as well as the virus, which actually are able to take advantage. Well, the host is disadvantaged in terms of cooler weather. The virus has an advantage in terms of survival in cooler weather, and that together can be contributing to increase in terms of transmission. Obviously, also what happens during the winter period is people are more likely to gather in closed, poorly ventilated areas, which obviously, again, assists in terms of virus transmission. So there is possibly a climatic factor associated with this. In fact, there was an article that's a modeling study that's explored this, which also suggests that there might be a climatic factor associated with the efficiency of the virus to transmit, as well as the survival of the virus, and consequently, the type of epidemics that we can expect.
Oh, okay. We also have another question from an anonymous attendee who is saying that since viruses and outbreaks such as the SARS-CoV-2 will continue to arise due to human interaction with nature and animals, what are the measures that are being put in place to reduce the possibility of more outbreaks occurring in the future?
Yeah, so that speaks to the whole issue of what is known as a One Health concept, where we need to start thinking not just of human health, but the human zoonotic interface and how they actually how that interaction actually increases the susceptibility of humans, in particular, to being infected by organisms, by pathogens that are usually only found in the animals. So what needs to be done? I mean, you might have heard in China as an example, they've basically implemented a significant amount of restrictions in terms of the trade of wildlife. So that is one sort of example. But what it also requires is much greater investment on our side in terms of using a One Health approach. It requires more collaborations between the medical fraternity and the veterans. The veterinary fraternity. So I think it's something that has been talked about. The NIC, the National Institute for Communicable Diseases, as an example, collaborates closely with Undersport, which is where the veterans work. And I think that whole concept of One Health needs to sort of be dealt with in more depth, including in South Africa. Interestingly, in South Africa, one of the most contagious, one of the most dangerous viruses that are found in bats that pose a threat to humans is not Ebola virus, it's actually Marburg virus. And Marburg virus is actually found in bats in a cave in Limpopo, right? So that virus is actually in South Africa, but because we don't have the same sort of interaction between bats and humans in South Africa, unlike in West Africa, where Ebola was able to get past that sort of species barrier because of consumption of bats, as an example. We don't see that outbreak happening in South Africa, but these sort of viruses are present in South Africa. These highly potentially pathogenic viruses are present in South Africa. And it really requires sort of a collaborative approach in terms of being able to detect at an early stage whether these pathogens are crossing the species barrier.
Okay, that's perfect. And Rowan is asking that given that we are already having different studies in South Africa, are you able to share any preliminary results of the vaccine so far that you are involved in?
Yeah, so the way the vaccine studies are done is that volunteers are randomly allocated to one of two groups, and both the volunteers as well as investigators are blinded in terms of whether they're receiving a vaccine or a placebo. And that's required for us to be able to do the type of analysis that we're wanting to do in terms of whether there are any differences with side effects of the vaccine, as well as whether the vaccine protects against COVID-19. So we can only do an unblinding when we're ready to do that sort of evaluation. So right now, we're still sort of following up individuals. We need to be able to, as an example, have at least about 42 of the 2,000 participants that have enrolled into the first trial to develop COVID-19. And only at that stage do we have what we call adequate power to be able to make a firm conclusion as to whether the vaccine protects against COVID-19 or not. So we can't sort of, on an ongoing basis, do interim analysis because that might bias our approach in terms of determining whether the vaccine protects against COVID-19 as well as its safety profile. So it's difficult to predict when we're going to accrue those number of cases. Initially, I thought it would be as early as November of this year, but with the waning of the outbreak, it's probably going to take us longer to accrue 42 individuals that developed COVID-19 before we can do the analysis. And it looks like now we would probably need to extend right into the first quarter of next year before we're able to do that analysis.
Okay, all right, Prof. And there is someone, just to tie in with what you're saying right now about the number of participants that we have. Someone is asking here that how can we participate in the study without being a part, of the subjects that are being tested?
Well, there's obviously volunteers that are wanting to participate in the study. If people are asking if there's any other role that they can play in terms of assisting us with the study, the short answer to that is probably yes. And it's not just about the vaccine studies. So my research unit is involved in a number of other studies trying to understand how COVID-19 is affecting pregnant women or how COVID-19 has affected healthcare workers and or number of how many people in the community have been infected. So there's a number of other opportunities other than just a vaccine study for students to come forward to participate. And in fact, we're paying students right now to assist us with some of the studies. So again, I think I sort of shared that email address, and my address is the same as any other VETS address. So feel free to reach out to me if you're interested in assisting us in any way, and I'm sure we can find opportunities.
Okay, so there is someone who would like for them to take a stand in terms of them asking the questions. And I don't know if Tembi and them can be able to assist in putting them up.
So I've got the question. Do you want me to go through the questions in front of me?
Okay, so they wanted to personally ask the question.
Oh, sure. Okay.
Yes, but then we can always just come back if they are not ready yet. So there is a question. Are they ready?
Thank you so much. Yes, I'm ready. Thank you so much.
All right. You can go ahead.
Thank you so much, Prof, for this informative session. I'm really learning a lot as well. I must say that I'm not in the medical fraternity, but I'm in the legal fraternity, but I've got interest right now through this seminar as well that has been organized by the Office of the Dean. But I've got like two quick questions, Professor. One is what changes to the vaccine presentable disease surveillance are recommended, like if the vaccine or if the COVID-19 pandemic does not allow for existing VPD surveillance system to continue normal. And the other one as well, other question is, during this pandemic, of course, should we reduce or suspend, immunization programs in school-based system? If we were to reduce or suspend those programs, what should be communicated to the concerned? What should be communicated to the concerned parents who are worried about their children missing the vaccine doses? Thank you so much.
Yeah. So thanks, those are really both important questions. And I'm going to take the second question first, because I think that's a really, really important question. And it's not just about school-based vaccine programs, it's about childhood vaccination in general. And the majority of vaccines that are given to children, in fact, are given in the first 2 years of life. And the estimate right now by UNICEF indicates that because of the impact that the response to COVID-19 has had on healthcare services, and there's a number of reasons why it's impacted on healthcare services, including in South Africa, where staff that are responsible for providing immunization have been sort of redeployed to assist with COVID-19 responses. Parents have been frightened to come forward to clinics to have their children vaccinated. Is that we've in South Africa alone have seen a 25 to 30% decline in terms of the number of children under the age of 2 that are being vaccinated against life-threatening diseases. Globally, the estimate, we know that COVID-19 doesn't cause severe disease in children. They're relatively protected. But despite that, we expect anything between 250,000 and 1.2 million children to die indirectly because of COVID-19. And a large percentage of those deaths are children that are going to die simply because they didn't actually gain access to immunization facilities and they weren't vaccinated. And this is not unique to COVID-19. It's a similar experience that was sort of realized in terms of Ebola vaccine in West Africa, or Ebola in West Africa, where the number of people that died in the most recent outbreak in the DRC from Ebola was about 3,500. The number of children that have died from measles, which is vaccine preventable, is double that number, 6,000. And there were close on to 300,000 children that developed measles in the DRC. Again, because of the disruption in terms of immunization services. So the bottom line is that we need to safeguard immunization services in the midst of a COVID pandemic rather than wait for us to plan a catch-up campaign of those children. And that is something which unfortunately we weren't proactive with in South Africa. I think things are getting better now. We've seen an increase in terms of the number of people that are being vaccinated. So that is good news. But there is this gap that's been created in terms of under-immunization of children, which is something that we need to redress. In terms of the school vaccination, there's only one vaccine that's really used in the schools, and that is the HPV vaccine, the human papilloma virus vaccine for children, for girls especially. And with that vaccine, fortunately, it's not a vaccine that is going to put someone at risk tomorrow from a severe outcome. So there is opportunity in terms of catching up with the HPV vaccine in the school environment. So I wouldn't be too concerned about it. But I think more generally in terms of vaccine, there definitely is a need for us to focus and get children that have missed out on immunization to be vaccinated as soon as possible. In terms of your question on surveillance and vaccine preventable diseases, unfortunately, that is a casualty of a casualty of our response to COVID-19. So it's similar to the disruption in terms of immunization services. There's been disruptions in terms of a number of other health parameters, including surveillance and vaccine preventable disease. And there's also been disruption in terms of care of people with HIV, and there's been disruptions in terms of people not being tested at the same rate that we were testing them previously for tuberculosis, and a delay in terms of diagnosis of tuberculosis. And all of that, unfortunately, is going to lend itself to an increase in terms of mortality and morbidity from TB and HIV. And what I'm hoping doesn't happen is that increase in terms of mortality because of the indirect impact of our response to COVID-19 actually exceeds the number of deaths that were prevented from COVID-19. And that is something that we're looking at right now.
Okay. All right, Prof. So we are running a bit out of time. I just have two important questions. The first one is from an anonymous attendee who they're asking that, and that is a big if, a vaccine had to be discovered, what percent, like discovered in Africa, I think that's what they meant to say, what percentage will Africa have access to it of? And so that is the first question. And then the second question, which unfortunately will be the last, is from Mandi Sangema, who is asking that from the experience you have as per your credentials, contribution towards the medical fraternity during the pandemic, and most importantly, as an incoming dean of the Faculty of Health Sciences, do you think it is important for medical students to have a scientific research background?
Yeah, both great questions. And I'm really passionate about the second question more than the first question.
Yes.
Just to be clear, we're not going to discover a COVID-19 vaccine in Africa. And unfortunately, I've gone into it. We haven't invested enough in terms of science to be able to do this sort of discoveries. But we can play a role in terms of the clinical development and evaluation of the vaccine, which is what we're doing currently. Does it guarantee that we're going to gain access to the vaccine at an early stage? It certainly puts us in a much more competitive position than had we not been involved in these studies. So as part of my agreement with the companies that, with at least one of the two companies whose vaccines that we're actually evaluating, is that should the vaccine shown to be effective in South Africa, we would pretty much go to the front of the queue in terms of being able to gain access to that particular vaccine. It's not going to be for the entire population of South Africa, but it certainly is going to be at least for high-risk individuals, maybe 5% of the population, healthcare workers, and other high-risk individuals in the short term. So I think it puts us in a much more competitive position than compared to had we not been involved in any of this clinical development of the vaccine. In terms of the second question, I think this speaks to the whole issue that I sort of tried to allude to, and that there simply hasn't been enough investment in terms of science. And when I'm talking of the investment, it sort of transcends across boundaries. And it starts off in the university. And our curricula in the medical fraternity, in School of Medicine, is simply not geared to basically assist people to make informed decisions in terms of pursuing a research career pathway. It's something that happens completely by accident in a medical faculty, and I'm an accident of that. I ended up in research purely by accident and not by design, right? And that is something that I would like to see this faculty redress. We need to really look how we train undergraduate students, how we introduce them to the concepts of research, how we actually encourage and promote them to start getting involved in research as undergraduates, not as postgraduates, because your undergraduate years are your formative years in terms of where your career is going to lead to. And if we don't install that sort of culture in the mindset of students as undergraduates, we're simply going to be in the same space as we are right now in 20 years from now. And I've qualified from the medical school in 1990, and I hate to say that between 1990 and when I speak to third and fourth and fifth year medical students now, not much has changed in terms of the curriculum, not much has changed in terms of exposing them to research, and that is a major problem. If we as Africans are wanting to take center stage when it comes to science and discovery, we need to be able to do that starting off with our undergraduate students and not waiting for accidents of nature to happen before a few people come through the process.
All right, thank you so much, Prof. And we're hoping that since you're going to be you are the incoming dean to the Faculty of Health Sciences, you will just ensure that we do not have accidental discoveries of researchers, but rather that the faculty or rather the university becomes very much inclined in growing scientists and health professionals that are very much inclined in terms of research and science, so that we just prove that we do have it also in us as Africans to be the discoveries of such vaccines. Thank you so much. I would just like to hand over back to Mr. Jerome September, our Dean of Students, to just do a vote of thanks. Thank you so much.
It's a pleasure.
Thank you. Thank you, Prof, for having shared this afternoon with us, for having shared so generously with us. I think the importance of this conversation cannot be overestimated. We have young people on this platform, either currently in a leadership position on campus, or as we know, given who WITS graduates are, will be in leadership positions beyond university. And I think what this conversation does is that it brings to the fore in our leaders' minds the scientific endeavor, the dynamics involved, the wealth of work that's being done, and it's pushing our leaders to think very carefully about their own positions, to think very carefully about, as they think about this campus and the growth and development of this campus, to think carefully about the voices that they listen to, the voices they give power to, and the voices that informs the decisions that they make. Many students here might not know that when the decision was made back in March to close campus and to bring the recess period forward, that we were talking as the institutional leadership to people like yourself. And we were quite clear that it was going to be the science that will help inform the leadership decisions. So students as leaders, this conversation, we're talking about a COVID-19 vaccine development, we're talking about scientific endeavor, but we're also talking about the choices you make as leaders. Prof said more than once, we have as a continent not invested in research and development. We have not invested in science. And because we have not invested, we now, in the face of a global pandemic, we find ourselves almost at a back foot in terms of leading the discovery for a vaccine. But even amidst that difficulty, here we have people like Prof Madhi, who's part of the global processes. And so it is for us to think about as leaders, how do we think globally, but from a local perspective? And how do we invest into the future? So I've taken quite a bit from this conversation. I think I know a little bit more now about COVID and the vaccine and the processes involved and this idea of the second and the multiple waves that are potentially coming. But importantly also about thinking about the future and thinking about how we grow and develop our continent, how we grow and develop our institution, and that challenge that he put out around thinking at undergraduate level already about research, thinking at undergraduate level already about a research career, so that we as Africans from our position can really begin to tackle not only local problems, but global problems in an interconnected world. So I hope that you all enjoyed this. Pastor, thank you so much for having chaired the session so wonderfully. We are delighted that you could join us and that you could lead us in this tough conversation. Thank you to those in the background who have made things work, people from events, Tembi in my office. Thank you so much for that. This webinar series is about challenging us. It is about making students think deeper. It is about making students question their own positions. And so I hope that you will also join us, students, for the future ones that are ahead. And here's an advertorial for the next two. Our next speaker will be Linda Mafu. She is with the Global Fund in Geneva. She's a social activist, and that focus will be around social activism and how, and just leadership lessons in that space. She used to be with the treatment action campaign as well, and is now working at a global level in the social activism space. That's the next one. The one following that one, and this person needs no introduction, will be our Chancellor, Dr. Judy Dlamini, who will come and speak to us about leadership lessons from her journey. And then at the end of September, beginning October, there's going to be an extra special surprise, which I will not divulge now. You will have to watch your inboxes for that. But thank you so much for having joined us. Again, thank you, Professor Madhi, for having shared so wonderfully. We wish you all the best on this journey, and we also wish you all the best in your role, your new role as the Dean of Health Sciences Faculty. Thank you, everyone, and good night.
Thank you.
Thanks.